I want you to imagine a 47-year-old brilliant ophthalmic surgeon. Let's just call him JP.
Right.
So he graduated from medical school with distinction. He has this thriving, highly respected practice, a 28-year marriage, adult children. I mean, by every societal metric you can think of, he is the absolute picture of upper middle class success.
Yeah, the classic high achiever.
Exactly. But lately, something is unraveling. He is experiencing these profound, just crushing depressive symptoms. A really severe free-floating anxiety has completely taken hold of him. And, most terrifyingly for a surgeon, he has this pervasive cognitive fog.
Which is terrifying.
Right. He feels like he just isn't thinking clearly anymore, and his hands aren't quite as steady as they used to be, especially in the morning.
Yeah.
So his wife is obviously deeply concerned because he's started retreating. He spends hours isolated in his study every single evening, just alone, door completely shut. So finally, his primary care physician refers him for a psychiatric evaluation.
And, I mean, that referral represents a massive diagnostic crossroads. Because when a highly functioning middle-aged professional presents with mood changes, severe anxiety, and cognitive clouding like that, the differential diagnosis is just incredibly broad.
Right. And as a non-clinician looking at this, my immediate thought is, well, this man is just under immense stress.
Sure.
Why wouldn't a doctor just immediately assume it's, I don't know, major depressive disorder or generalized anxiety disorder, or even, given the cognitive fog, maybe the very early, terrifying stages of a dementing process, like early onset Alzheimer's?
Because those are entirely logical conclusions. I mean, they are exactly the trap that many unintentioned clinicians fall into every day.
Really?
Absolutely. In fact, in this specific case, JP had already been in cognitive behavioral therapy for 6 months to address his mood swings and his physical complaints, but he was making absolutely zero progress. And this is exactly why the psychiatric approach, the deep investigative, almost forensic history taking is so vital, because JP is the quintessential example of how an alcohol use disorder basically masquerades as other independent psychiatric illnesses.
Great alcohol, but he doesn't fit the picture. I mean, when you say alcohol use disorder or AUD, the image that immediately flashes into most people's minds is, the tragic extreme stereotype.
Yes.
The person who has lost everything, drinking out of paper bag on a park bench, completely unmoored from society. JP is a successful surgeon.
And that stereotype is clinically, statistically, and just fundamentally erroneous.
Is it?
Yeah, it's a dangerous societal myth that prevents millions of people from getting help. To understand how alcohol actually infiltrates a life, we really need to reframe our entire perspective. I want you and our listener to imagine a detective. Let's call him Medlock Holmes.
Okay.
Holmes is invited to investigate a bustling, vibrant city. And at the absolute center of this city is a grand, historic tavern. It appears to be the focal point of almost every celebration and life event.
So it's woven completely naturally into the fabric of the society.
Exactly. People gather there to unwind after a grueling day. Families book tables to celebrate their most cherished milestones. High-stakes business deals are forged over its polished counters, and great victories are toasted under its lights. Right. At first glance, it seems to offer nothing but joy, connection, and freedom. But Holmes, being an astute observer, he begins noticing a much darker, hidden pattern.
What does he see?
Well, he sees that the same people keep returning to this tavern not because they wish to celebrate, but because they've forgotten how to stop.
Oh, wow.
Yeah. What once appeared to offer freedom has quietly, almost invisibly, become a source of absolute dependence. Relationships fracture in the shadows. Brilliant careers like JP's slowly stall and decline. Anxiety and depression take root among the regulars.
That's insidious.
It is. Alcohol rarely arrives as the villain. It often enters life as a friend and quietly becomes the master.
That is a chilling metaphor. It doesn't invade, it assimilates. And that is the core mission of our deep dive today. We are exploring how this transition from friend to master actually happens, how it hides in plain sight, and the exact biological mechanisms behind it.
Spot on.
For you listening, this deep dive is a companion to Chapter 11.2 of Kaplan and Sadok's comprehensive textbook of psychiatry. But we aren't just here to recite a list of symptoms, are we?
No, not at all. We are here to build mental models. We want to clarify the hidden mechanisms of addiction and strengthen your clinical reasoning.
Right.
To ground our investigation, we really must establish a foundational anchor. We are looking at this through the lens of psychiatry. And psychiatry at its core is the study of how brain, mind, and experience interact, and crucially, how that intricate process can go wrong.
Yeah.
We're analyzing the intersection of a powerful pharmacological agent, individual neurobiology, and complex human behavior.
Okay, let's unpack this and point that lens back at JP. If he was hiding in plain sight, how did the psychiatrist finally uncover the truth?
It required careful, non-judgmental interviewing, and crucially, this is key, gathering collateral information.
Meaning speaking with his wife.
Exactly, speaking with his wife.
Yeah.
When the psychiatrist probed deeper into JP's routines, particularly those locked-door evenings in his study, the pattern of an AUD became undeniable.
What was the pattern?
Well, JP had recognized his drinking was becoming a problem, so he tried to cut back. He would set a strict limit for himself. He promised himself a 2-glass limit of wine after dinner.
Okay, seems reasonable.
Right, but once he had that first glass, the neurochemical cascade began. He would routinely consume 2 entire bottles, alone in his office, simply to achieve a baseline feeling of normality.
So he was trying to set a limit and failing every single night.
Yes, every night. And the critical revelation for the clinician was the severe depression, the crushing anxiety, the cognitive fog. These were not primary independent psychiatric disorders.
They weren't.
No, they were the downstream neurochemical consequences of heavy chronic alcohol consumption and the daily mini withdrawals he was experiencing every single morning before surgery.
Wow. That fundamentally reshapes how you view the patient. And JP is not an anomaly, is he? If we look at the scope of this hidden master, the epidemiology is staggering.
It is massive. To completely dispel that stereotype of the homeless alcoholic, you just have to look at the clinical reality. Alcohol use disorders affect 20 to 30% of middle-class men.
30%?
Up to 30%, yeah. And about 15% of women who are actively seeking medical care in primary settings. The typical patient sitting in a doctor's waiting room with an undiagnosed AUD has a job. They live with their family. They're relatively high-functioning members of society.
So you wouldn't pick them out of a lineup?
You absolutely would not. Yet, they are likely to die a decade or more prematurely.
20 to 30% of middle-class men in a medical setting. That is a silent epidemic. And alcohol is unique among drugs, isn't it? I mean, it's completely socially accepted, heavily marketed, culturally ingrained, yet it's a pharmacologically powerful central nervous system depressant.
It is entirely unique.
Yeah.
In the United States, about 90% of Americans have consumed alcohol at some time in their lives.
Mm-hmm.
During any given year, 70% of individuals are current drinkers. The economic cost of the problems associated with this consumption is almost $250 billion a year in the U.S. alone.
That's hard to even conceptualize.
It is. Globally, the World Health Organization estimates that 134 million disability-adjusted life years are lost to alcohol.
And we can't pretend this is just some modern problem of stress, right? I mean, humans have been fermenting fruit and grain for an incredibly long time.
Oh, yeah. We have evidence of human consumption dating back at least 12,000 years.
Yeah.
It was deeply integrated into ceremonies in Babylon, ancient Greece, the Roman Empire, for pleasure, nutrition, and supposed medicinal properties.
Right.
But the volume of consumption fluctuates wildly depending on the era. For context, in the 1700s, people were drinking an estimated 5 gallons of absolute ethanol a year.
5 gallons.
Yeah. It was often safer than drinking the water. Today, the global average is lower, but we are tracking highly concerning modern trends.
What kind of trends?
Well, between 2001 and 2013, the overall rate of alcohol use disorders increased by about 10%.
Okay.
But hidden within that data is an absolutely alarming 85% increase in AUDs among women during that same period.
An 85% increase in women, that drastically shifts the demographic understanding of who is walking into the clinic.
Absolutely.
So if the presentation is changing and it hides so well behind other symptoms, how do psychiatrists actually officially define the disorder today? The terminology can be confusing. People use terms like alcoholic, alcohol abuse, alcohol dependence.
Yeah, the nosology, the classification of the disease has evolved significantly to reflect a better understanding of the pathology. We have largely moved away from stigmatizing terms like alcoholic in clinical settings.
Makes sense.
Currently, the 2 major diagnostic systems are the DSM-5, which is used heavily in North America, and the ICD-11, developed by the World Health Organization and used globally.
Right.
They approach the categorization slightly differently, but they completely agree on the core clinical picture, which is repeated impairments in multiple life areas as a direct, undeniable result of alcohol use.
Let's break down the DSM-5 first, because I know that's a staple for trainees. How does it conceptualize the disorder?
So in previous iterations, the DSM separated abuse and dependence, but the DSM-5 merged them into a single continuous spectrum called alcohol use disorder. It outlines a list of 11 specific criteria.
What kind of criteria are we looking for?
They fall into a few broad categories. First, impaired control. This includes taking alcohol in larger amounts or over a longer period than intended.
Oh, so this is exactly JP's situation, intending 2 glasses and drinking 2 bottles.
Precisely. It also includes a persistent desire or unsuccessful efforts to cut down and experiencing intense cravings.
Okay.
Second category is social impairment. This means failing to fulfill major role obligations at work, school, or home, or giving up important social, occupational, or recreational activities because of alcohol use.
So, like the father who stops going to his kids' football games because he'd rather stay home and drink?
Right.
Or our surgeon retreating to his study?
Spot on. The third category is risky use, such as drinking in physically hazardous situations like driving or continuing to drink, despite knowing it's causing or exacerbating a physical or psychological problem. And the final category is pharmacological criteria, the development of tolerance and withdrawal. To be diagnosed with an AUD, a patient needs to exhibit at least 2 of these 11 criteria occurring within a 12-month period.
And how do you gauge how bad it is? Is it just a binary, you have it or you don't?
No. It's graded by severity based on the number of criteria met. 2 to 3 criteria indicate a mild AUD. 4 to 5 is moderate. 6 or more of the 11 criteria represents a severe alcohol use disorder.
That makes a lot of sense. It treats it as a spectrum rather than a cliff you fall off. How does the ICD-11 compare? Does it use the same checklist?
The ICD-11 takes a slightly more conceptual thematic approach. It focuses heavily on what we call the triad of dependence.
The triad of dependence.
Yeah. To meet the diagnostic guidelines, a patient must demonstrate at least 2 of 3 central features over a 12-month period, or continuously for at least 1 month.
What is the triad?
The first pillar is impaired control over alcohol use, regarding the onset, level, or termination of drinking. Again, this encapsulates the phenomenon of craving. The second pillar is that alcohol use becomes an increasing priority in life, taking precedence over other interests, daily activities, and responsibilities, despite negative consequences. The third pillar, and this is deeply physiological, is the presence of neuroadaptation.
Neuroadaptation, the brain physically changing its structure and function to survive the drug.
Yes. The ICD-11 defines this neuroadaptation by the presence of tolerance, withdrawal symptoms upon cessation, or the persistent use of alcohol specifically to prevent or relieve withdrawal symptoms.
Okay, that concept of neuroadaptation is the perfect bridge to the next massive phase of our deep dive. The mechanisms, the why of alcohol. We know the what people drink, they lose control, their relationships fracture, their careers stall.
Yeah.
But how does a simple liquid do this to the most complex organ in the universe? Let's trace the journey of the molecule. What happens the second someone takes a sip?
Well, ethanol is a remarkably simple, small, water-soluble molecule. Because of this, it requires absolutely no digestion. None. When you drink it, absorption begins immediately through the mucosal lining of the mouth, the esophagus, and the stomach. However, the vast majority of the uptake, the most prominent area of absorption, occurs in the proximal small intestine.
Now, I noticed something fascinating in the source material regarding this specific location. The proximal small intestine isn't just where alcohol is absorbed, it is also the primary site for the absorption of many vital B vitamins, isn't it?
That shared geography in the gut is a critical piece of the puzzle. It is not a coincidence. It is a profound biological vulnerability.
How so?
When a person engages in chronic heavy alcohol use, the constant presence of ethanol essentially damages and inflames that mucosal lining. It actively destroys the gut's ability to absorb those crucial B vitamins from food.
Oh.
Yeah, this localized damage in the intestine is what ultimately leads to severe, devastating neurological damage in the brain later on. But for now, returning to the ethanol once it passes through that intestinal wall, its high water solubility means it is instantly distributed throughout the entire body, effortlessly crossing the blood-brain barrier.
So it's in the bloodstream, it's bathing the brain, it's infiltrating every organ. The body must view this as a threat. How does it get rid of it? Because this is where the biological bottleneck seems to happen.
The body absolutely treats ethanol as a toxin that must be cleared to maintain homeostasis. A small fraction between 2 and 10% is excreted completely unchanged through your breath, your sweat, and your kidneys.
Which is the physiological basis for breathalyzers, right?
Exactly. But the vast majority, over 90%, must be metabolized and broken down, primarily by the liver. And this hepatic metabolism is a slow, multi-step enzymatic process.
Okay, let's unpack this metabolic factory in the liver, because understanding this explains so much about human drinking behavior.
So the first step occurs in the cytosol, the fluid inside the liver cells. An enzyme called alcohol dehydrogenase, or ADH, goes to work on the ethanol molecule, breaking it down into a substance called acetaldehyde.
Right.
Now, this specific step is the rate-limiting step of the entire process. It is a strict biological bottleneck.
Why is it a bottleneck? I mean, if I drink 5 beers in an hour, why can't my liver just recruit more ADH enzymes to clear it faster?
Because the ADH enzyme cannot function independently. It is essentially a factory worker that requires a highly specific tool to do its job.
What's the tool?
That tool is a cofactor called nicotinamide adenine dinucleotide, or NAD. And the liver only possesses a relatively limited fixed supply of NAD at any given time.
Oh, I see.
Once the available NAD is in use, the ADH enzymes literally have to wait. Consequently, the liver can only process roughly 1 standard drink per hour, equating to a drop in blood alcohol concentration of about 15 milligrams per deciliter per hour.
Wait, so if the liver only has a set amount of NAD tools, does that mean all those famous hangover cures, chugging black coffee, taking a freezing cold shower, going for a run to sweat it out, are they just biological fiction? You can't speed up the factory.
That is precisely what it means. You cannot accelerate the primary metabolic pathway.
Right.
The factory workers only have so many tools. Until the NAD is recycled, the excess alcohol simply continues to circulate in the bloodstream, bathing the brain in a depressant.
Okay, so the ADH factory workers slowly take the ethanol, they use their limited NAD tools, and they convert it into acetaldehyde. Now, let's talk about acetaldehyde, because this molecule is a fascinating character in our story. In my head, I picture acetaldehyde as a toxic middleman. It's a highly reactive, highly unpleasant compound.
It is profoundly toxic. Acetaldehyde is arguably more damaging to the body's tissues than the ethanol itself. Oh, yes. At high circulating levels, it triggers the massive release of histamines and catecholamines. Clinically, this manifests as rapid, unstable fluctuations in blood pressure, intense and uncomfortable facial flushing, severe nausea, vomiting, and a racing, pounding heartbeat.
That sounds awful.
It is an intensely aversive, deeply unpleasant physical experience.
But if it's that toxic, why don't most of us feel like we've been poisoned every time we have a single glass of wine with dinner?
Because in a typical metabolic system, a second shift of factory workers steps in almost instantaneously.
Okay.
A second enzyme, called aldehyde dehydrogenase, or ALDH, rapidly swoops in and neutralizes the toxic acetaldehyde, breaking it down into a harmless substance called acetate.
And what happens to the acetate?
That acetate is eventually just fed into the body's normal metabolic pathways and excreted as water and carbon dioxide. Because this ALDH enzyme works so efficiently, the average person maintains exceptionally low levels of toxic acetaldehyde in their bloodstream while drinking.
But this is where the genetics become incredibly important. What happens if a person is born with a genetic mutation where that second shift of work, the ALDH enzymes are basically defective or asleep on the job?
This specific genetic variation is one of the most powerful, biologically fascinating protective factors against developing an alcohol use disorder in the entire world.
A protective factor?
Yes. We are referring to a mutation on chromosome 12, specifically the ALDH22 allele. This mutation is highly prevalent in certain populations. It is observed in approximately 40% of Japanese, Chinese, and Korean individuals.
What actually happens to them if they consume alcohol?
If an individual inherits 2 copies of this mutated gene, meaning they're homozygous for ALDH22, their ALDH enzyme is practically non-functional. They lack the biological machinery to efficiently metabolize that toxic middleman. So if they consume even a minimal amount of alcohol, 1 or 2 standard drinks, acetaldehyde rapidly and aggressively accumulates in their bloodstream. They immediately experience that violent antabuse-like reaction, the extreme nausea, the racing heart, the severe drop in blood pressure.
So their body essentially rejects the drug outright.
Exactly. Because drinking makes them violently physically ill almost instantly, their genetic risk for developing an alcohol use disorder drops to virtually 0. Their biology simply will not allow them to tolerate the substance long enough to develop a behavioral addiction. It acts as a built-in biological deterrent.
That is incredible. A genetic mutation that shields you from addiction by making the drug intolerable. Now, we have to contrast that powerful protective factor with a genetic risk factor.
Yes.
Because the psychiatric literature talks extensively about something called the low level of response, or low LR. I've heard this discussed, but I want to understand the mechanics. What makes a low LR so dangerous?
Well, if the ALDH mutation makes you hypersensitive to the toxic effects of alcohol, a low level of response makes you dangerously, deceptively undersensitive to the intoxicating effects.
Undersensitive.
Right. People with a low LR naturally require much higher doses of alcohol to feel the desired sedation or euphoria to get a buzz, so to speak.
So these are the people you meet in university who have this legendary ability to just drink everyone under the table right from their very first party.
Precisely. And while certain cultures or social circles might praise that as a badge of honor or a sign of fortitude, from a psychiatric perspective, it is a massive, glaring red flag.
Why is it a red flag? Shouldn't a strong constitution be a good thing?
Because to achieve the psychological effect, they desire the relaxation, the social lubrication. They are forced to consume much larger quantities of ethanol per occasion.
I see.
This heavy drinking inevitably alters their social environment. They naturally gravitate toward peer groups of other heavy drinkers where this volume is normalized. More insidiously, it cements heavy alcohol use as their primary, deeply ingrained coping mechanism for stress.
That makes total sense.
Interestingly, functional MRI studies suggest there is a cognitive inefficiency in these individuals. Their brains literally struggle to register the neurochemical effects of lower alcohol doses. Consequently, possessing a genetically influenced low level of response is one of the most significant predictors for developing a severe alcohol use disorder later in life.
It's a tragic irony. The people whose bodies seemingly handle the drug the best are actually the ones whose biology is setting them up for devastation.
Exactly.
Okay, so we've established how the molecule navigates the gut and the liver and how genetics alter its breakdown. But we need to go up to the brain. Because alcohol is classified as a central nervous system depressant. It's not just making us sleepy, it is fundamentally altering our neurochemistry.
It is. In psychopharmacology, alcohol is often described as a dirty drug.
A dirty drug.
Yeah, unlike modern psychiatric medications that target a very specific receptor, ethanol is a simple molecule that floods the entire system, fundamentally disrupting almost all major neurochemical pathways. But to truly grasp its primary mechanism of action, we must examine the delicate, essential balance of the brain's circuitry.
To help visualize this, I picture the brain's neurochemistry as a giant, incredibly sensitive seesaw. The brain's ultimate goal is homeostasis. It is always trying to keep that seesaw perfectly level.
That's a great way to look at it.
On one side of the seesaw, you have all the relax, inhibit, and sleep signals. On the opposite side, you have the excite, stimulate, and wake signals.
That is a highly accurate conceptual model. The primary weight on the relaxed side of your seesaw is a neurotransmitter called gamma-aminobutyric acid, or GABA specifically. It operates through the GABA receptor.
Okay, GABA.
GABA is the brain's main inhibitory signal. Its job is to slow the nervous system down, induce sleep, relax the musculature, and reduce anxiety. When ethanol crosses the blood-brain barrier, it acts as a massive amplifier for GABA. It effectively throws a heavy lead weight onto the relaxed side of the seesaw. This is the fundamental reason alcohol acts as a depressant. It aggressively enhances sedation and significantly impairs motor coordination.
And what is happening on the other side of the seesaw? Because if the relaxed side is weighed down, the excite side is up in the air.
The main counterweight on the excite side is a neurotransmitter called glutamate, which primarily binds to NMDA receptors. Glutamate is the brain's primary excitatory signal. It is responsible for keeping you awake, keeping you alert, and crucially, forming new memories.
Okay.
Alcohol doesn't just amplify GABA, it simultaneously directly dampens and blocks these excitatory NMDA receptors.
So it's a double hit.
A massive double hit. Not only is alcohol pushing the relaxed side down with tremendous force, but it is also simultaneously lifting the excite side up by removing the brain's natural stimulation. The seesaw slams violently down completely on the side of depression, sedation, and lethargy.
But the brain is a survival machine. It hates being out of balance. It cannot survive if its nervous system is completely depressed and unresponsive to the environment.
Exactly. The brain's biological imperative is survival, and a heavily depressed nervous system is a severe vulnerability. So if a person, like our surgeon JP, drinks heavily and continuously day after day, The brain initiates a physical, structural adaptation to survive the chemical siege.
The neuroadaptation.
Yes, this is the profound neuroadaptation we defined earlier in the ICD-11 criteria. To force that seesaw back to a level state, the brain downregulates, meaning it decreases the number and sensitivity of the GABA receptors. The brain essentially says, we're receiving too much relaxation signal, let's dismantle some of our receivers.
It's deafening itself to the GABA.
Yes, and simultaneously it upregulates, it physically builds more excitatory NMDA receptors. It is desperately, aggressively adding weight to the excite side to counteract the constant daily flood of the depressant alcohol.
And that adaptation, that desperate structural balancing act by the brain, is the biological definition of tolerance.
It is.
But this is where the terminology gets nuanced, because tolerance isn't just one monolithic concept. When I hear the word tolerance, I usually just think, it takes him 6 beers to feel drunk instead of 2. But in clinical psychiatry, you break tolerance down into 3 distinct, separate mechanisms.
We must separate them, because understanding which mechanism is at play directly dictates the clinical treatment plan. The first type is behavioral tolerance.
Right.
This is purely a learned compensatory phenomenon. A person learns, through sheer repeated practice, how to perform complex tasks effectively while intoxicated.
So they're just masking it.
Exactly. They learn how to consciously mask their slurred speech. They concentrate intensely to walk in a straight line, and they learn how to hold a coherent conversation while possessing a blood alcohol level that would render a novice drinker completely unconscious.
This is the functional alcoholic hiding in plain sight, like JP operating a clinic while mildly intoxicated.
Precisely. The second type is pharmacokinetic tolerance. This brings us back to our liver factory. When you flood the liver with toxic amounts of alcohol every single day, the liver recognizes the crisis and adapts.
How does it adapt?
The primary ADH factory workers are overwhelmed, so the liver essentially tears down a wall and builds a second, entirely different conveyor belt to help clear the toxin.
Oh, wow.
Right, and this secondary pathway is called the microsomal ethanol oxidizing system, or MIOS.
I love that image. Tearing down the wall to build a backup system.
It is an effective backup system. It clears the alcohol from the blood much faster, which is why the person needs to drink more to keep their blood levels up. However, this MIOS conveyor belt is highly inefficient and creates a tremendous amount of toxic oxidative stress and exhaust in the process, further damaging the liver over time.
And the third type of tolerance?
The most profound and clinically dangerous is pharmacodynamic, or cellular tolerance. This is the seesaw adaptation we just explored in detail. The actual nerve cells in the central nervous system change their receptor density and sensitivity. The neurons literally remodel themselves to function normally, despite being constantly bathed in high concentrations of a central nervous system depressant.
Which brings up a terrifying concept mentioned in the textbook, cross-tolerance.
Yes.
If JP's brain has adapted to resist alcohol, a depressant, by actively downregulating those relaxing GABA receptors, it stands to reason that his brain is now highly resistant to other depressant drugs as well.
That is a vital clinical deduction.
Yeah.
If a patient with severe pharmacodynamic alcohol tolerance stops drinking and is admitted to a hospital for surgery, the anesthetist will face a major challenge.
Because the usual drugs won't work as well.
Exactly. The patient will often require significantly higher doses of anesthetic agents or sedatives, like benzodiazepines, to achieve sedation. Their brain is already structurally heavily fortified against depressant drugs.
That is wild.
Conversely, if an active heavy drinker mixes alcohol with another depressant, like a barbiturate or a prescription benzodiazepine, the effects don't just add together. They potentiate, they multiply exponentially. This is a highly lethal combination that frequently results in respiratory failure, coma, and death.
It's an incredibly terrifying tightrope. But we have to address the elephant in the room. If alcohol is just suppressing the brain, making you sleepy, clumsy, and eventually toxic, why do people ruin their lives over it? Why is it so aggressively addictive?
To answer that, we have to look beyond the GABA-NMDA seesaw and examine the brain's reward circuitry. Alcohol consumption acutely triggers a significant spike in the release of dopamine.
Dopamine.
Right, specifically targeting the ventral tegmental area and the nucleus accumbens, which are the brain's ultimate pleasure, reward, and reinforcement centers.
So it's hijacking the system designed to keep us alive.
Exactly. It chemically tricks the brain into registering the consumption of alcohol as a deeply vital, life-sustaining activity on par with eating a nutrient-dense meal or reproducing. However, chronic drinking eventually blunts and exhausts this dopamine response. This blunting drives the intense, desperate craving. The person eventually has to drink larger and larger amounts, not to feel euphoria, but just to feel a baseline level of normal pleasure or motivation.
So the magic is gone, but the need remains.
Furthermore, alcohol increases serotonin levels in the synapses and heavily interacts with the brain's natural endogenous opioid systems. It is not just a depressant, it is an orchestrated neurochemical manipulation of the highest order.
So we have this simple molecule. It easily bypasses the liver's metabolic bottleneck. It floods the central nervous system. It drastically tips the GABA-NMDA seesaw. It violently hijacks the dopamine reward center, and it literally forces the neurons to fundamentally remodel their architecture.
That's a perfect summary.
That is the biological why. Let's transition to the clinical manifestations. When the brain and the body undergo this level of chronic chemical siege, what actually happens to the patient in the real world?
The manifestations exist on a spectrum, beginning with acute intoxication. The severity of the impairment is directly linearly correlated to the blood alcohol concentration, or BAC.
Right.
For context, in the US and the UK, the legal limit for driving is typically 80 milligrams per deciliter, or 0.08 grams per deciliter. But profound cognitive impairment begins far below that legal threshold.
Walk us through that progression because it escalates quickly.
At merely 20 to 30 milligrams per deciliter, you observe slowed motor performance and a measurable decrease in complex thinking ability and divided attention.
This from 1 or 2 drinks.
Yes. Between 80 and 200 milligrams, you see serious ataxia, which is severely impaired, stumbling coordination along with major judgment errors, emotional ability where a patient might switch from laughing to weeping instantly, and profound cognitive deterioration.
And then the blood levels push into the 200 to 300 milligram range. And this is where we encounter a phenomenon that I think is widely and dangerously misunderstood by the general public, the blackout.
The alcoholic blackout is a critical, often ignored clinical warning sign. Studies suggest up to 50% of all social drinkers have experienced one at some point, but repeated, frequent blackouts strongly indicate the presence of a severe AUD.
I think a lot of people use the term casually. They equate blacking out with passing out, lying unconscious, and asleep on the floor. But clinically, that's not what a blackout is it?
Not at all. Passing out is simply alcohol-induced sleep or stupor. A true blackout is a state of en bloc anterograde amnesia.
Anterograde amnesia.
Yeah. The person is fully awake. They are conscious, walking, talking, perhaps driving a car, sending complex emails, or engaging in a heated argument. But because the dose of the brain depressant is so extraordinarily high, a specific region of the brain called the hippocampus, which is responsible for consolidating short-term experiences into long-term memories, is essentially chemically paralyzed.
Oh, wow.
The brain simply stops hitting the record button.
That is deeply unsettling.
It is terrifying. The individual continues to interact with the world, but the next morning they have a permanent, irreversible gap in their memory. They cannot recall how they got home or what they said, despite having been entirely conscious and seemingly functioning during the events.
To be operating your physical body while your memory consolidation system is completely offline. And if blood levels continue to rise past 300 or 400 milligrams per deciliter, the depressant effect overcomes the brainstem.
Right.
You are looking at the first stages of general anesthesia, respiratory failure, coma, and ultimately death. But intoxication is just the acute phase.
What about the chronic toll?
The slow systemic destruction over years. Because culturally, we usually just equate alcoholism with liver damage. We think, alcoholism equals cirrhosis.
Cirrhosis is absolutely a severe risk. Approximately 15% of patients with chronic AEDs develop this irreversible fibrous scarring of the liver tissue. Cirrhosis can lead to a cascade of fatal complications, including bleeding esophageal varices, ascites, and hepatic encephalopathy, where liver toxins enter the brain and cause confusion and coma.
But
But if we connect this to the broader systemic picture, liver failure is not the leading cause of early deaths in these patients.
wait, really? If it's not the liver, what is killing them?
Heart disease.
Yeah.
Chronic heavy alcohol intake aggressively elevates blood pressure and increases levels of LDL cholesterol and triglycerides. But more directly, at sustained high doses, ethanol acts as a striated muscle toxin.
It's toxic to muscle.
Yes, it actively deteriorates the myocardial tissue, the heart muscle itself. This leads to a condition known as alcoholic cardiomyopathy, resulting in dangerous beating irregularities, an enlarged, weakened heart, and eventually congested heart failure.
It's literally poisoning the structural tissue of the heart. And what about sleep? This is a massive one because so many people, even those without an AED, use a nightcap to help them fall asleep. They view alcohol as a sleep aid.
Using alcohol as a sleep aid is a massive, highly destructive clinical illusion.
Why is that?
While a large dose of a depressant might decrease sleep latency, the time it takes to lose consciousness, it completely destroys the architecture of the sleep cycle. Alcohol heavily suppresses REM sleep, which is vital for cognitive restoration, and it inhibits the deep restorative stage 4 delta wave sleep.
So you are unconscious, but you aren't actually resting.
Exactly. And it gets worse. As the alcohol is metabolized by the liver in the middle of the night and blood levels drop, the brain experiences a mini withdrawal.
Ah, the seesaw again.
Exactly. The suppressed excitatory system rebounds. This leads to severe sleep fragmentation, frequent awakenings, sweating, and intense, vivid, often disturbing dreams. The patient wakes up feeling exhausted, anxious, and jittery.
That sounds miserable.
It is. For someone with a severe AUD, their sleep architecture is so deeply disrupted that it might not return to a normal, healthy pattern until they have been completely abstinent for 3 to 6 full months. And that lingering, agonizing insomnia during early recovery is one of the single highest risk factors for relapse. They drink just to seek the oblivion of unconsciousness again.
The body is just under constant, relentless assault. The textbook mentions that it affects the blood-producing systems as well, causing something called macrocytosis.
Yes, macrocytosis is the presence of abnormally enlarged red blood cells. The toxic environment created by chronic alcohol exposure interferes with the normal maturation of red blood cells in the bone marrow, causing them to release into the bloodstream larger than they should be.
So it's affecting bone marrow too.
We also see profound suppression of the immune system, leaving patients highly susceptible to infections like pneumonia. It vastly increases the relative rates of cancers of the head, neck, esophagus, stomach, liver, and breast. It frequently causes peripheral neuropathy, a permanent, painful, burning, tingling, and numbness in the hands and feet due to nerve damage.
And we must absolutely touch on the teratogenic effects, because alcohol doesn't just affect the person drinking it.
That is a critical public health point. Any amount of alcohol is potentially harmful to a developing fetus. High, continuous doses cause fetal alcohol syndrome, a tragic condition characterized by severe developmental delays, low IQ, distinct facial abnormalities, and congenital heart defects.
It's devastating.
Even lower doses contribute to fetal alcohol spectrum disorders, leaving children with lifelong invisible impairments in executive functioning, impulse control, and attention deficit.
It is truly a systemic poison. Here's where it gets really interesting, though, because I want to return to the brain. There is a specific, devastating neurological manifestation that occurs at the intersection of alcohol, severe nutritional deficits, and genetics. Let's explore Wernicke-Korsakoff syndrome.
Wernicke-Korsakoff syndrome is a relatively rare but utterly profound alcohol-induced major neurocognitive disorder. It is fundamentally caused by a severe systemic deficiency in thiamine, which is vitamin B1.
And this connects perfectly back to our discussion about the gut. We mentioned earlier that alcohol is primarily absorbed in the proximal small intestine, which is the exact same location where the body absorbs B vitamins like thiamine from our food.
Exactly. The chronic inflammation from the alcohol destroys the gut's absorptive capacity. Furthermore, patients with severe AUDs often derive the majority of their daily caloric intake directly from the alcohol itself, leading to profound systemic malnutrition.
They just aren't eating.
Right. They simply aren't eating enough thiamine-rich foods, and what little they do eat, they cannot absorb.
But not every single patient with severe AUD gets this syndrome. Why do some develop it and others don't?
It typically manifests in individuals who possess a pre-existing genetically influenced vulnerability, specifically a deficiency in an enzyme called transcatalyase.
Transcatalyase?
Yes. Transcatalyase is crucial for brain metabolism, and it absolutely requires thiamine as a cofactor to function. When the environmentally induced severe thiamine deficiency collides with this genetic transcatalyase vulnerability, you get a devastating two-stage neurological syndrome.
Walk us through the two stages. What does a patient look like when they present with the first stage?
The first stage is called Wernicke's encephalopathy. This is an acute, life-threatening neurological emergency. It presents clinically with a classic, highly recognizable triad of symptoms.
What's the triad?
Severe confusion or delirium, prominent ataxia, which is a wide-based, unsteady stumbling gait because the cerebellum is starved of energy, and thirdly, a palsy of the sixth cranial nerve.
What does that mean for the patient's eyes?
It means the muscles controlling eye movement are paralyzed. Their eyes cannot track properly. They develop severe nystagmus, a rapid involuntary flickering of the eyes, or they may have complete paralysis of lateral eye movements.
If a patient presents in the ER with this triad, is Wernicke's reversible?
It can be highly reversible, provided it is recognized immediately and treated aggressively. But if the clinician misses the diagnosis or if the treatment is delayed, the acute encephalopathy progresses inevitably into the second-stage Korsakoff syndrome.
And what happens in Korsakoff's?
Korsakoff syndrome is a chronic, and in at least 50% of cases, permanent neurological condition. The defining characteristic is a profound, irreversible anterograde amnesia. The patient completely loses the neurological ability to form any new memories. Their hippocampus and surrounding structures are permanently damaged.
So they are trapped in the past.
Essentially, yes. But fascinatingly and tragically, to fill in the gaping, terrifying blank spaces in their memory, these patients will frequently confabulate.
Confabulate, meaning they lie.
No, it is crucial to understand they are not lying or trying to deceive you. They will invent highly detailed, incredibly plausible-sounding stories to explain where they are, who you are, or what they did yesterday.
Why did they do that?
If you ask a patient who has been in the ward for a month what they did that morning, they might tell you in great detail about walking their dog and buying a newspaper. Their damaged brain is desperately, automatically trying to construct a continuous narrative reality to cover the gaps.
The tragedy of Korsakoff's is immense. You mentioned treating Wernicke's aggressively to prevent this permanent damage. How exactly is it treated? Because the textbook emphasizes a very specific, non-negotiable protocol.
You cannot simply hand the patient a multivitamin pill or suggest they eat a better diet. The mandated clinical treatment is high-dose intravenous thiamine. We're talking about 500 milligrams the fourth, administered 2 to 3 times a day for several consecutive days.
Why must it be intravenous?
Because oral thiamine, even at high doses, simply cannot achieve the massive serum concentrations required to force the vitamin across the blood-brain barrier rapidly enough to rescue the dying neurons. It must be driven into the brain intravenously.
High dose the thiamine. A crucial, potentially life-saving clinical pearl. Okay, so we have built a robust, detailed model of what alcohol does to the gut, the liver, the neurochemistry, and the systemic organs. Now let's step into the shoes of the clinician. Let's transition to integration and clinical reasoning.
Brilliant.
Because a psychiatrist's mind isn't just lugging a list of biological facts. They're using these models to solve incredibly complex diagnostic mysteries in real time.
And the most complex mystery in addiction psychiatry is untangling causality. When a patient sitting across from you is drinking heavily and is also deeply depressed, or they're experiencing severe panic attacks, or perhaps they're even hearing auditory hallucinations, how do you know what the primary driving illness is?
Right.
Do they have an independent schizophrenia? Do they have an independent major depressive disorder? Or is the alcohol causing all of the psychiatric symptoms?
That is the ultimate clinical puzzle. If someone is heavily intoxicated, of course they might seem depressed and sluggish. If they are in withdrawal, of course they are anxious and panicked. How does a psychiatrist separate the true signal from the drug-induced noise?
The single most valuable diagnostic tool the psychiatrist possesses in this scenario is not a functional brain scan, and it's not a genetic test. It is the timeline.
The timeline strategy. Unpack this for us. How is it deployed?
To differentiate an independent psychiatric disorder from an alcohol-induced one, the clinician must act like an investigator and construct a meticulous chronological history of the patient's entire life. We are actively searching for specific periods of time when the psychiatric symptoms existed without the presence of heavy alcohol use.
Okay.
We look for 2 specific temporal clues. First, did the severe depression or the anxiety clearly antedate? Did it begin before the onset of the heavy problematic drinking?
So if they were depressed at age 15 but didn't start heavy drinking until age 25, the depression is likely independent.
Exactly. The second and most clinically useful clue requires looking at periods of cessation. Have the psychiatric symptoms ever persisted during a period of at least 1 month of complete verified abstinence?
Why is 1 month the magic window?
Because the neuroadaptation we discussed, the altered seesaw of receptors, takes time to heal. But clinical data shows that alcohol-induced psychoses, alcohol-induced severe depressions, and alcohol-induced anxiety disorders will almost always clear spontaneously within a few days to a maximum of 4 weeks of stopping drinking.
Wow.
And they clear without the need for independent antidepressants or antipsychotic medications. The brain simply resets itself. If the depression or the hallucinations remain severe after 4 or 5 weeks of zero alcohol, you are highly likely dealing with an independent psychiatric disorder that requires separate, dedicated pharmacological treatment.
The textbook provides a really illuminating case study that highlights this perfectly. There was a 48-year-old woman referred to psychiatry for new-onset severe panic attacks. She was having them 2 to 3 times a week for 6 straight months. She reported no obvious life stress, no trauma, and no medication side effects. But the clinician looked at her routine blood work and noticed some glaring anomalies.
Yes, her carbohydrate-deficient transferrin, or CDT, was elevated at 3.5%. Her gamma-glutamyl transferase, or GGT, was elevated at 47. These are known as state markers for heavy drinking.
So the blood told the story.
This crucial biological evidence prompted the clinician to gently but firmly probe her alcohol history, eventually speaking with both her and her spouse to get the collateral truth. It turned out she was suffering from a hidden, highly secretive alcohol use disorder.
So using the timeline strategy, the clinician asked, have you ever had these panic attacks during periods in your life when you weren't drinking heavily? And she said no. During her past, brief periods of abstinence, the panic vanished completely.
Right. So the working diagnosis shifted dramatically. It was not an independent panic disorder. It became an alcohol-induced anxiety disorder, specifically related to the mini withdrawal she was experiencing between drinks.
That's a huge shift in treatment then?
Absolutely. The prescription wasn't Xanax or a daily SSRI, which would have complicated her addiction. The prescription was medically supervised abstinence and cognitive behavioral therapy. She was treated for moderate withdrawal, and within 3 weeks of stopping drinking, her brain's GABA and NMDA balance restored itself, and the panic attacks completely disappeared.
It's incredible clinical detective work. You mentioned her blood tests, GGT and CDT. Let's decode these lab tests because psychiatrists use them like forensic evidence to uncover the hidden master. What exactly are they looking for, and what do these acronyms mean?
These are referred to as state markers, meaning they reflect the body's current physiological reaction to recent heavy drinking, usually defined as 5 or more standard drinks a day over several weeks. GGT is a liver enzyme.
Okay, GGT.
If it's over 35 units per liter, it strongly suggests recent heavy drinking because the liver is inflamed. But GGT is highly sensitive and drops quickly. It can return to a normal baseline after just 2 to 4 weeks of complete abstinence.
What about the other one, CDT?
Carbohydrate-deficient transferrin is a specific protein marker in the blood. A level over 3.0% is highly indicative of heavy sustained alcohol intake. What makes CDT exceptionally useful for psychiatrists is its half-life. It has a biological half-life of about 16 days.
Oh, I see.
This makes it an excellent, reliable tool for monitoring a patient in early recovery over the course of a month to ensure they are genuinely maintaining abstinence.
And there's a third major classic marker, MCV, mean corpuscular volume.
Yes, this ties back to our discussion on the blood system. An MCV over 91 cubic micrometers indicates macrocytosis, the presence of those enlarged red blood cells we discussed earlier. But here is the critical, often tested caveat for clinical reasoning. MCV is an excellent historical marker for identifying a long-term heavy drinker, but it is utterly useless for short-term relapse monitoring in a recovery program.
Why is it useless for relapse? I mean, if they drink, won't the cells get big again?
Because of the biological lifespan of the cells. The lifespan of a red blood cell in the human body is roughly 120 days. Once the toxic alcohol environment has enlarged a generation of those cells in the bone marrow, they stay enlarged and circulate in the blood for 4 entire months, even if the patient stops drinking entirely the next day.
4 months?
Yes. You have to wait for the bone marrow to produce an entirely new, healthy generation of red blood cells before the MCV value finally drops. Conversely, if a sober patient slips up and drinks for 2 days, it won't immediately spike the MCV because the circulating cells are still normal. So a high MCV tells you about the patient's behavior over the last few months, not the last few days.
That makes perfect mechanistic sense. It's a fossil record of their drinking.
Yeah.
There are newer, even more precise tests, too, like PSYCH, which stays elevated for 1 to 2 weeks, and ETG in the urine, which can catch a single slip-up over the past 48 to 72 hours. It really is forensic science.
It truly is.
But gathering this data, confronting the diagnosis, and agreeing to stop drinking it inevitably leads the patient into the most physically dangerous phase of the entire disease process, the crisis of withdrawal.
And to truly understand the violence of withdrawal, we must return to our fundamental model, the seesaw.
Yes, the brain had adapted to survive. It downregulated the relaxing GABA receptors and massively structurally upregulated the excitatory NMDA receptors just to stay level under the heavy daily weight of the alcohol.
Exactly. Now, imagine the patient suddenly, abruptly stops drinking. The heavy weight of the depressant is instantly removed from the GABA side of the seesaw.
Right.
But the brain still possesses all those extra highly sensitive, structurally reinforced NMDA receptors on the excitatory side. With the alcohol suddenly gone, the excitatory side slams into the ground. The brain is thrust into a state of massive, unopposed neurochemical excitation.
An excitatory storm. And what does that electrical storm look like clinically when a patient is sitting in front of you?
The storm begins predictably within about 8 hours of the last drink. The patient first experiences a coarse tremor of the hands, profound insomnia, intense inner anxiety, and severe autonomic hyperactivity. Their pulse rockets upward, their blood pressure spikes dangerously, they sweat profusely, and they may hyperventilate.
And it gets worse from there.
In some cases, usually peaking around day 2 or 3, this unopposed electrical storm in the cortex triggers a generalized tonic-clonic seizure, often called a grand mal seizure.
The textbook outlines 2 fascinating case studies regarding withdrawal that really highlight how dangerous this period is, especially when it's hidden. Let's talk about the case of FT first. The 73-year-old retired professor.
FT's case is a tragic textbook example of the broader medical system missing the signs of the hidden master. He was a retired professor who had recently moved to a new retirement community. Over several years, he had slowly, quietly escalated his drinking to 6 standard drinks a night, mostly just through socializing at the community center. He goes into the local hospital for a routine elective hernia repair surgery.
And the surgical team completely misses the impending disaster.
They took a brief, superficial preoperative history that entirely missed his daily drinking pattern. They also completely ignored his routine pre-op labs, which showed an elevated GGT of 55 and an elevated MCV of 93.5.
So the evidence was there.
It was. They performed the surgery successfully, but 8 hours later, as he recovers on the surgical ward, the alcohol completely leaves his system. His pulse rockets to 110, his blood pressure hits 150 over 100. He begins sweating profusely, his hands shake violently, and then, completely unexpectedly for the surgical team, he suffers a massive grand mal seizure right there in the recovery bed. He wakes up violently agitated, hallucinating, and completely disoriented.
He went into full-blown alcohol withdrawal delirium.
Yes. Historically known as delirium tremens, or DTs, it occurs in less than 5% of all alcohol withdrawals, but it is a life-threatening medical emergency. It is characterized by severe autonomic dysfunction, profound confusion, agitation, and terrifying visual and tactile hallucinations. Patients often see insects crawling on the walls or feel them on their skin. FT's brain was essentially short-circuiting, screaming for the depressant it had adapted to.
Now, contrast FT's accidental, chaotic, unmanaged withdrawal with the case of Mr. T, the 64-year-old lawyer.
Mr. T had a highly documented 35-year history of severe AUD. He was a highly functional professional, but deeply physiologically dependent. He had tried to stop drinking multiple times on his own, and he knew exactly what the terrifying tremor, the sweating, and the insomnia felt like.
Right.
So how did he survive his self-imposed detox periods at home? He self-medicated, he procured, and took 5 or more 10-milligram capsules of chlordiazepoxide a day.
Chlordiazepoxide is a prescription benzodiazepine. It's in the same family as Valium or Xanax.
Precisely. And this action perfectly illustrates the dangerous principle of cross-tolerance we discussed earlier. Alcohol and benzodiazepines are both central nervous system depressants. They both exert their primary effects by enhancing the GABA receptor. By taking the chlordiazepoxide, Mr. T was artificially putting a different pharmaceutical weight back onto the GABA side of his brain's seesaw.
I see.
This prevented the seesaw from tipping into the excitatory storm, staving off the seizures and the delirium. He was essentially performing a crude, unmonitored medical detox on himself in his living room.
Which is incredibly dangerous to do without medical supervision. When he finally sought professional medical help because his hypertension and diabetes were out of control, his doctor wisely admitted him to a medical setting for a supervised withdrawal. The notes say he had a pulse of 110 and a blood pressure of 150 over 96, while his blood alcohol level was still 50 milligrams per deciliter.
Exactly.
His body was going into severe withdrawal before the alcohol was even fully out of his system. His cellular tolerance was so extraordinarily high.
Which seamlessly bridges us into treatment and key takeaways. Because Mr. T's dangerous self-medication strategy actually points directly to the pharmacological mechanism of how we officially safely manage detoxification in a hospital setting.
So how do clinicians actually approach helping these patients? Because you can't just walk into JP's clinic or Mr. T's office and yell at them to stop drinking. You mentioned earlier that aggressive confrontation simply doesn't work.
It absolutely doesn't. Decades of data show that hostile confrontation increases resistance and drives the patient further into the addiction. The first stage of treatment is intervention, and it must be built on a foundation of empathy and collaboration. We use a brief intervention model called FRAMES.
FRAMES. Let's break that acronym down. How does a psychiatrist use FRAMES?
It stands for providing clear feedback on the personal medical risks, showing them their elevated liver enzymes or blood pressure. Emphasizing the patient's personal responsibility for change, we cannot force them. Offering clear, non-judgmental advice to reduce or stop drinking. Providing a menu of treatment options so they feel empowered. Communicating with genuine empathy, not authority. And finally, facilitating self-efficacy, building the patient's belief that they can actually achieve change.
Yeah.
We rely heavily on motivational interviewing. We explore their ambivalence.
Right.
We gently connect their drinking behavior to the very things they're complaining about, like JP's cognitive fog or his marital strife. We guide them to the realization that alcohol is the hidden variable destroying the things they value most.
And once they reach that realization and agree to stop, we enter the detoxification stage.
Right.
And we use the exact mechanism Mr. T used, but safely and scientifically.
Yes. For mild or moderate withdrawal, the essential pharmacological step is substituting the short-acting depressant alcohol with long-acting depressant, typically a long-acting benzodiazepine like chlordiazepoxide or diazepam.
So you're giving them a controlled weight for the seesaw.
Precisely. By administering a long-acting benzo, we artificially and smoothly stabilize the GABA seesaw. This prevents the life-threatening seizures and the delirium. Then, over the course of about 5 to 7 days, we slowly, incrementally taper the dose of the benzodiazepine down to 0.
Which allows the brain to adjust.
This slow taper allows the brain's receptors the crucial time they need to gently readjust and downregulate back to a drug-free state without crashing violently into an excitatory storm.
And what if it's severe? What if they present in full-blown delirium tremens like the retired professor, FT, thrashing and hallucinating?
DTs represent a medical emergency that requires an intensive care unit. The mortality rate is significant, up to 20% historically if left untreated. We must use very high frequent doses of intravenous benzodiazepines. We may also use adjunctive antipsychotics like haloperidol to manage the severe hallucinations and dangerous agitation. If the patient's cross-tolerance is so high that they are entirely resistant to massive doses of benzodiazepines, critical care physicians may use continuous infusions of propofol or dexmedetomidine to induce a state of deep, arousable sleep, essentially putting the brain in a medically induced coma to protect it until the excitatory storm finally burns itself out.
It is a profound systemic medical crisis. But detoxing the patient over a week is just the beginning of the journey. The alcohol is physically out of the system, but the brain is still injured. Which brings us to the third stage of treatment rehabilitation. Because that massively upregulated excitatory system, all those extra NMDA receptors, they don't just instantly vanish and go back to normal after 5 days of detox, do they?
We most certainly do not. After acute detox, patients enter a challenging phase called protracted withdrawal. For 2 to 6 months, they will experience mild but persistent lingering anxiety, anhedonia, and inability to feel pleasure, mood swings, and most dangerously, that fragmented non-restorative sleep architecture we discussed.
It sounds like a marathon.
Their brain is still slightly chronically hyperexcitable, and this constant low-level physical and psychological discomfort is a massive daily trigger for relapse. They just want the discomfort to stop.
So how do we help them survive those critical first 6 months?
Alongside vital, non-negotiable psychosocial interventions like cognitive behavioral therapy and mutual help groups like Alcoholics Anonymous, we have specific pharmacological tools to assist the healing brain. The most prominent one discussed in our source material is a medication called acamprosate.
How does acamprosate actually work in the brain?
Acamprosate is neurochemically fascinating. Its molecular structure actually resembles GABA, but it doesn't primarily act by stimulating GABA receptors. Instead, it works by antagonizing or blocking the hyperactive NMDA glutamate receptors.
Wait, hold on. Let me push back on that. You just said its structure resembles GABA, the very neurotransmitter that alcohol artificially boosts to cause this whole mess. If we are giving them a drug that resembles GABA, wouldn't that just restart the cycle of addiction and tolerance? Aren't we just swapping one depressant for another?
That is an excellent, highly perceptive question, and it's a common point of confusion. The key difference is that acamprosate does not bind to the GABA-A receptors in the same powerful, rewarding way that alcohol or benzodiazepines do. It doesn't cause a spike in dopamine, it doesn't cause sedation, and it has virtually zero abuse potential. Instead, its primary clinical action is modulating that excitatory glutamate side of the seesaw. It essentially acts as a chemical shock absorber for that hyperexcitable, damaged brain.
That makes perfect sense.
It calms the protracted withdrawal symptoms, eases the agonizing insomnia, and smooths out the mild, lingering anxiety without causing intoxication. Clinical trials show it significantly improves drinking outcomes, improving abstinence rates by 15 to 20% when used consistently over the first 6 months of recovery. It is not a magic cure, but it gives the healing brain a crucial, stable window to rebuild a life without alcohol.
So what does this all mean? If I'm looking at the grand synthesis of this deep dive, the vital paradigm-shifting takeaway is that alcohol use disorder is a profound systemic neurochemical adaptation. It is not a moral failing.
Absolutely not.
It is not a weakness of character or simply a lack of willpower. The brain physically, mechanically remodels its own cellular architecture to survive the constant flood of a toxic depressant. And the clinical symptoms we see, from JP's crippling anxiety to the 48-year-old woman's panic attacks to FT's violent delirium tremens, are simply the biological echoes of that structural remodeling. The hidden master changes the very architecture of the mind.
That is a brilliant synthesis. AUD is a biological disease of neuroadaptation, frequently masquerading as a series of unrelated psychiatric and medical failures.
Which leads me to a final provocative thought for you, the listener, to mull over before we test your clinical reasoning. If alcohol essentially borrows peace from tomorrow by artificially suppressing the brain today, leaving behind a massive, compounding, excitatory debt that must be painfully paid back during withdrawal, how might our society's reliance on a drink to unwind after work be masking a silent, massive epidemic of low-grade, self-inflicted anxiety disorders? Are millions of people attempting to cure their daily stress with the exact chemical that is fundamentally generating it?
That is a profoundly important question, and it requires the precise, objective clinical reasoning we've been building today to answer it when those patients walk into our clinics. On that note, let us reinforce that clinical reasoning. Instead of a standard quiz, let's do a rapid-fire clinical role-play to test the mechanisms we've discussed. I will present a real-world scenario as if we are on the ward and challenge you to identify the underlying mechanism.
Okay, test my clinical reasoning here. Put me in the ER. Let's go.
Scenario 1. You are the attending psychiatrist in the ER. A 28-year-old man is brought in. He is terrified, claiming he is hearing voices commanding him to harm himself. He has a known 5-year history of heavy daily alcohol use, but his family says he hasn't had a drink in 3 days. The ER physician wants to diagnose him with acute schizophrenia and start heavy antipsychotics. Using the timeline strategy, what specific historical factor would prove to you that this is an alcohol-induced psychotic disorder rather than independent schizophrenia?
Okay, if it's alcohol-induced, the timeline is everything. I wouldn't care as much about his family history right now. I would want to know if these auditory hallucinations have ever persisted during a period of sustained abstinence. If his family tells me he had these voices last year, but after he was completely sober for a month in rehab, they went away entirely, then I know it's alcohol-induced. The brain resets itself within that 4-week window.
Spot on. Scenario 2. You are running a genetics research clinic. You have a patient who is homozygous for the ALDH22 allele. A medical student asks you why this patient is statistically incredibly unlikely to ever develop an alcohol use disorder. How do you explain the protective mechanism at a cellular level?
I would tell the student that this patient's liver is missing the second shift of factory workers. Their ALDH enzyme is non-functional. Because of this, they cannot metabolize acetaldehyde, the toxic middleman. If they take even one shot of liquor, that toxic acetaldehyde floods their system, causing severe flushing, nausea, and a racing heart. Their DNA has basically given them a permanent biological anabuse reaction. The drug is simply too punishing to become addictive.
Precisely. Scenario 3. You are paged to the surgical recovery ward. A patient who underwent routine surgery 12 hours ago is now experiencing severe tremors, a heart rate of 130, and is sweating profusely. They hid a severe drinking habit from the surgical team. At a neurochemical receptor level, what is driving this sudden, violent autonomic hyperactivity?
This is the excitatory storm. Because of their secret drinking, their brain had adapted by downregulating the inhibitory GABA receptors and massively upregulating the excitatory NMDA receptors. The surgery forced them to stop drinking, so the heavy depressant weight was instantly removed. Now, those NMDA receptors are firing completely unopposed. The seesaw has slammed down on the side of pure neurological excitation.
Excellent. Scenario 4. You are reviewing lab results in an outpatient recovery clinic. A 55-year-old woman recently completed detox. Upon admission 2 months ago, her GGT was elevated, her CGT was elevated, and her MCV was remarkably high at 102 cubic micrometers. She swears she has been completely sober for 2 months. You run the labs again today. Which of those three markers, GGT, CDT, or MCV, is most likely to still be abnormally elevated, even if she is telling the truth about her absolute abstinence?
It has to be the MCV, the mean corpuscular volume, because that marker measures the size of the red blood cells. The alcohol damaged the cells in the bone marrow 2 months ago, and those enlarged cells have a biological lifespan of 120 days. They're still floating around in her bloodstream. Her GGT and CDT would have returned to normal by now, but the MCV fossil record takes 4 months to clear.
Absolutely correct. Final scenario. A severely malnourished patient is brought in by ambulance from a homeless encampment. He is profoundly confused, his gait is so unsteady he cannot walk without assistance, and his eyes are constantly flickering with nystagmus. You recognize the triad of Wernicke's encephalopathy. What is the immediate, non-negotiable physiological treatment required to prevent him from developing permanent Korsakoff's amnesia, and exactly how must it be administered?
He has a severe thiamine vitamin B1 deficiency, likely compounded by a genetic transcatalis vulnerability. His brain is starving. I cannot give him an oral vitamin because his gut won't absorb it fast enough. The required treatment is high-dose intravenous thiamine. It must be IV to force the concentration high enough to cross the blood-brain barrier and rescue those dying neurons before the anterograde amnesia becomes permanent.
Perfect clinical reasoning across the board. I strongly encourage you, the listener, to direct your attention back to Chapter 11.2 of Kaplan and Sadok's Comprehensive Textbook of Psychiatry to review these profound mechanisms in even greater detail.
Medlock Holmes eventually realized that the tavern wasn't just a building in the city. It was actively rewriting the map of the streets, changing the flow of traffic, altering the very foundations of the town until all roads naturally, inevitably led back to its doors. The brain does the exact same thing. It structurally remodels itself to accommodate the friend that quietly became the master.
Here are the details of this episode.
Alcohol-related disorders. Byline. Alcohol rarely arrives as the villain. It often enters life as a friend and quietly becomes the master.